From theheart.org, Medscape Cardiology. This is the Bob Harrington Show. Dr. Robert Harrington is the Arthur L. Professor and Chair of Medicine at Stanford University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington from Stanford University on Medscape Cardiology and theheart.org. Those of you who have listened to this podcast series over the years know that one of the things I routinely like to go back to is talking with physician authors. Sometimes it's people who are prominent essayists. Other times it's people who have written books. I do it for a couple of reasons. Number one of which, I'm a very dedicated reader. And so I'm always reading. I always have a stack of books either at my bedside or on my iPad. And I really enjoy the pleasure that reading brings to me, whether it's fiction, biographies, historical novels. And it really does give me a break from my day job, if you will, to really concentrate on the imagination that others bring to their work. And I particularly have enjoyed interviewing physician authors because I'm fascinated that many of us in academic medicine spend our lives writing, but we write in a very prescribed format. We write science papers, we write editorials, we write viewpoints, write review articles. But the work it takes to produce an original book, I think, is extraordinary. And I admire greatly my physician author colleagues. And today is no exception to that. It's really a pleasure for me to be introducing a friend and colleague, Dr. Jag Singh. Jag is a cardiologist at the Massachusetts General Hospital and electrophysiologist. He's the Roman de Sanctis Professor of Cardiology at the Massachusetts General Hospital, and he's a professor of medicine at Harvard Medical School. Jag, thanks for joining us here on Medscape Cardiology and theheart.org.
Thank you, Bob. It's an absolute honor and a privilege to be here.
Well, I have a preprint copy here of Jag's book, Future Care, Sensors, AI, and the Reinvention of Medicine. It's an absolutely fabulous read. I always like to ask the question, why did you do this? You're an accomplished academic. You're a busy clinician. You're a physician scientist. So talk to me about why you did this, why you tackled this, because many of us think about writing books, but few of us do.
The book had been bubbling in my system for several years. I think I thought of writing it about 7 or 8 years ago. I started writing it about a year prior to COVID, and then it got catalyzed by the whole COVID situation to really lead to where it is now. And the reason for writing it was largely because I think, we're going through this digital transformation right now. And at this point in time, I think healthcare is really non-sustainable the way it is. There are so many issues plaguing it on a daily basis, not just the United States, but all over the world. And I felt that really advancing the theory of digital transformation, advancing the theory of using sensors with virtual care that is powered by predictive analytics with sustainable workflows can really transform care as a whole. And it landed up being a confluence of some of my research work in the past, and then eventually, obviously, my clinical work, and then add to that my little experience as a patient, and all kind of brought together the book, which I think really deals with how healthcare can be transformed.
Well, sometimes authors, and in this case, this is true, are geniuses at underselling. And I think you're underselling the prologue, which I think you said something to the effect of, it starts with my COVID-19 journey. If you don't mind, talk a little bit about that, because I found it incredibly moving. I remember March of 2020, when we didn't know what was going on, where we were trying every day to gather information from Italy, from China. On the West Coast, we were trying to gather information from you in Boston and New York, who were hit early. But that was a scary time. We didn't know what we were dealing with. We didn't know the treatments. We didn't understand all of these issues around oxygenation. And yet you were thrown into that. Talk about that a little bit and how that really informed what you were going to do.
I saw COVID from both sides. I saw it as a patient as well as a physician, but my initial experience was as a patient. I was probably amongst the first clinicians in Boston, maybe certainly in Mass General, to get inflicted by COVID that required hospitalization and a day in the ICU, teetering on whether I needed to go on support or not. Was glad not to. But it gave me a different perspective about care. I now looked at everything from a different vantage point. And I think a lot of my personal experiences helped change the tone of the conversation for this book too. So as I told you, I started writing this book a year before COVID, but the entire tone of the book really changed. The humanistic appeal of the book changed as I began writing it after I experienced COVID. And I realized that, we can talk about all these technological revolutions, but if they don't have a humanistic appeal, they're really meaningless. If they don't really impact care, they're really meaningless. You rightly point out that we knew nothing at that point in time. I was randomized to the placebo arm of remdesivir at that point in time. I got azithromycin and hydroxychloroquine, which are banned because we didn't know better at that point in time. So there were a lot of learning experiences for me as a patient as well as a physician that I think helped me understand how medicine should be practiced.
I'm really happy to hear that you were in a clinical trial at the time. Thank you for doing that. I will tell you a funny story about hydroxychloroquine. I was the president of the AHA when the pandemic started. We were putting out all sorts of pieces on what do we know? I mean, can you take ACE inhibitors? Is that going to increase your likelihood of infection? Why is it the cardiac patients are more likely to both get infected and to get really sick? And we put out a piece in collaboration with other groups, including your own professional society, Heart Rhythm, on QT prolongating drugs, like hydroxychloroquine, like azithromycin. And we said, basically, just be cautious. If you have patients with cardiac disease and you want to give them these QT prolongating drugs, be careful. That's all we said. On a Friday, Nancy Brown from the AHA, she's the CEO, as you know, she called me. She said, what are you doing tomorrow? And I said, why is that? She said, because we have to talk to the White House. They're not happy about our piece on QT prolongating drugs. So one of the highlights of my AHA presence.
As a follow-up to that, after I got well, I was involved in an AI-based study looking at hydroxychloroquine effects on the QT interval of the Whoop watch in France using a cloud-based algorithm. So, we were trying to really shift care and monitor patients. So it's really interesting.
Well, as you went through this experience and you begin to see your own, as you said, on both sides of the bedside, as we like to say, one of the things I noted is that you dedicated your book not to a family member or to a mentor, you dedicate it to nurses. And as the father of two nurses, I was really pleased to see that. But was that out of your COVID experience, out of your long experience as a clinician? I thought it was beautiful. And I'm just curious as to where that came from.
Well, thank you for noticing that. So I obviously, I work with nurses every day, and you often land up taking a lot of what they do for granted. And then you get ill and you realize they're the only ones who actually are looking after you. And I think the care I got by the nursing staff who looked after me while I was there in the hospital for the 10 or 11 days had a profound influence on me. I always deeply respected nurses, but I think seeing it from the other vantage point really highlighted the role they play in medicine and how much truly they are the soul of the healthcare nation. And the saying about how happy a hospital is dictated by how happy the nurses are at the bedside, also kind of rung true. So I think we don't give our nurses as much of credit as they deserve, and how much the impact they have on all our patients on a daily basis. As physicians, we come in and walk out and leave, but the 99.9% of the care is the nursing care. So that's the principal reason. It's just a dedication. I wish I could say more.
Well, you in a way did say more, and that I was struck also. Eric Topol writes the same thing, that sensors and virtual care and the digitization of medicine, AI, if we do it right, can bring back some of the humanity of medicine. Because maybe it frees clinicians up for the human aspect of things. And you talk about that. And it struck me in your prologue that the doctors are talking to you via the iPad, but the nurses are coming in to take care of you. And there's that interesting, you could call it a juxtapositioning or a bringing together of the human touch with technology.
It was Francis Peabody who said that the secret of the care of the patient is in caring for the patient. And that's something I strongly believe in. And that's something my mentor, Dr. DeSanctis, preaches and lives by on a daily basis. And I think the book, I hope I bring that out, is that despite all the digital transformation, the human bond is central to effective and real care. And that's why even the cover of the book has, those two hands shaking. Despite the digitization of the hands, it means that the human contact and bond really needs to be preserved.
I really do think that comes out, because the other thing I was struck by, and I'd like to go through some of the sections, is all the patient stories and how the patient stories, not just your own, but patients you've cared for, patients you've known, enters into the dialogue of the book. Because it really did strike me that the human element, which is what people worry about, oh, technology is going to replace the human element. No. Let's use technology so that we can accentuate the human element. 4 sections of the book. Let's see if I can get these right. There was sensors, there was virtual care, there was artificial intelligence, and then there was, I would call it the policy piece. How do we make our health system sustainable? Let's start at the beginning. Sensors. You're a longtime researcher in the area of sensors. Like all electrophysiologists, you're also a gadget guy. So talk about what excites you as sensors, and where do you see their role here?
One of the things I feel about modern day medicine, Bob, is that it's very transactional. When I say transactional, we see patients at 3-monthly, 6-monthly, 12-monthly intervals, but we know that patients don't necessarily fall ill at those intervals, and that illness is a continuous, phenomenon out there, or the absence of illness is a continuous phenomenon. I think sensors really provide us the opportunity of really digitizing the human body, and allow us to have organ-specific strategies or integrated strategies to look after our patients, but really, I think, allow us to transform that transactional care into some form of continuous care, where we can predict and prevent disease. And I think the soul of this book is more on forecasting and prediction and prevention of disease. So I'm really excited about the fact that there's this slew of wearable sensors, and there's these multiple implantable sensors that I personally implant a fair number of them. And I think when these start cross-talking to each other, and with the use of a smartphone, the integrated information that can find its way into the electronic health record, we can really change the life cycle of many disease states. We can really control conditions. We can certainly contain atrial fibrillation, heart failure, limit the incidence of sudden death. So I think sensors really have a tremendous role in the future, but obviously they need to be integrated with some predictive analytics at the back end too.
Well, and the other thing you talk a lot about is the empowerment of patients. And maybe more broadly, I'll just say the empowerment of people. Because what's the statistic that we spend only about 1% of our lives on a yearly basis in active contact with the healthcare system? The rest of the time we're in the wild of life. What do you mean by that, the empowerment of people?
So there are multiple ways of looking at it, but I think the most simple way is, healthcare right now is non-sustainable because you need constant interaction with the healthcare system, which is not possible. So having self-management strategies put into play are going to be instrumental in how healthcare really evolves. We already have it happening for things like diabetes, right? The continuous glucose monitor has changed the way and the landscape of how diabetes is managed. And I think the same thing applies to organ-specific sensors that are evolving, whether it is for asthma or COPD or hypertension or atrial fibrillation or heart failure. I think having self-management strategies and clinicians empowering the patients to look after themselves and seek care if there is an issue, I think is probably the way medicine is going to evolve. There's this whole concept, which you know about, Bob, which we call as exception-based care, where you kind of follow the patient along, continue surveillance strategies, and when they fall off the wagon or there's an issue out there, then they come to your attention, and not something that you have to periodically keep seeing them, which I think is a waste of resources, time, and energy.
Yeah, you mentioned the diabetes story. The pediatric endocrinologists here at Stanford have done some amazing work showing that by actually empowering adolescents and young adults, by letting them manage their diabetes with continuous glucose monitoring, you actually get way better control than letting the medical system manage it. It speaks to the power of people taking control of their own bodies, their own lives. It's really amazing stuff. Let's go to virtual care. During the pandemic, this is how we all saw a lot of our patients, right? At least at the beginning. I mean, we shifted from doing, less than 10% virtual visits as a system to doing over 80% literally in weeks. I suspect at Mass General, you did the same.
We had the same shift in virtual care, and, somehow I'm a little upset by the fact that the pendulum is swinging back and we're moving away from the virtual care end of things. And I think a lot of that is regulatory issues. There is clearly the will of the people who would like to be seen virtually whenever they can be, wherever they are. And for a lot of reasons, it saves them a lot of concerns of traveling and waiting in the waiting rooms and then getting cross-infected and all the other things that are associated with it. I think the issue is regulatory, and that's why we're having this conversation. And I'm hoping that, some of these conversations will institute change outside in if they can't be inside out. And I think, virtual care, it requires a new level of learning. I think there's this whole concept of the virtualist versus the traditionalist, and I don't think they're two separate entities. I think there's a nice hybrid strategy in between the two. That will allow us to look after patients in a combined way, depending on which form of medicine needs to be practiced. One thing I think you may have been alluding to, and we saw that in our research, and we published related to this with virtual care, is that there was a deepening divide at the start of the pandemic in terms of who could get virtual care and who couldn't get virtual care. And that's something I think that the not only the pandemic, I think even digital technology really heightens us awareness of the fact that we need to be paying attention to the risk of digital inequity, because that in itself can lead to health inequity. And there are a lot of things we yet need to write on that front.
Yeah, people talk about, tech equity and trying to make sure that we're able to reach all members of society. I think that's critically important. More and more, everything has to be, phone-based, because many around the globe, that's how they access the internet. And we need to, I think, as a public policy, really work on a broadband and universal broadband. How do we make that? Should be like clean water in the 21st century. Third chapter, which I thought was one of the most fun, AI. You clearly, we talk about the hype and the hope of AI. You clearly have a lot of hope for AI, though you are cautious. I enjoyed reading your thoughts on how AI is going to help us with things like predictive analytics. Give us maybe a broad view on the use of AI in healthcare, and what are some of the missteps that you worry about?
I think there are many challenges with respect to AI. I think, first of all, the role of predictive analytics is largely dependent on the data sets you're using, and the acquisition of data itself, it can be a huge issue to make sure that the data you're using is representative of the subset of patients you're using the algorithm for, which I think is a big issue itself. And on top of that is integrating these into current systems, then making them scalable in itself, I think are big problems that need to be surmounted. And I think the biggest issue with clinicians right now is the lack of explainability within the AI algorithms and folks not having trust. So I think some of those issues are getting sorted out as we get more familiar with AI and the roles it can play. But I think it's going to be iterative. It's not something that's going to come in, sweep us, and change everything. I think folks are going to have to get used to it, get adjusted to the fact, and understand that these need to be interpreted and used in the clinical context with all the available knowledge that we already have, and not just go directly to AI as the solution. So there are many potential missteps that could occur, and I think some of those, hopefully there's enough regulatory oversight and guardrails to ensure that the ethical aspects of it, the privacy aspects of it are being looked into.
Yeah, for me as a clinical researcher, I hope that we take the same approach we would take to any other diagnostic or interventional tool, which is that you need to expose it to the rigors of investigation to see, is it adding? And is it adding in a positive way? And is it hurtful or harmful? And so just because it seems like this black box, there are ways to study it in a way to make sure that it's adding to care, not subtracting from care. And I think that comes out nicely in the book as well. I want to come to the hardest chapter in the book, which is the last one, on making it sustainable. And I'm going to read you one of the last sentences you wrote in the book, which is, you said, you believe virtual care strategies aided by sensors and AI, coupled with self-management approaches, will create sustainable disruption and appropriate reimbursement models. You want to tell us what you're talking about?
I think it's going to be an evolution of how reimbursement evolves. The current fee-for-service structure is non-sustainable, right? What it really perpetuates, Bob, is this whole affinity for volume and high margin situations, so you can make money rather than try to deliver the best possible care. So I think there is a transition towards value-based care. The transition, however, has been fairly slow. At the same time, there are shared saving strategies that are being implemented where, you have a capitated amount, and if you can provide some degree of continuous surveillance for a patient with self-management strategies rolled in, you could potentially change the outcome of those patients, and the shared monies from that could be equally distributed in the parties affiliated with that care. So I think that is one strategy that is evolving and will need to evolve if healthcare really needs to be sustainable. There is a future that we will be able to have reimbursement for self-management strategies. The problem is everybody looks at healthcare from just on a year-to-year basis. The insurance companies, if they were to even create incentives for you to help with these reimbursement models, look at you as just a one-year customer because you might shift your insurance company. And at the same time, hospitals are looking at their feet, hoping that they don't step over each other, and not really looking at the long-term vision of how the life cycle of this patient is more important than that singular episode. But I'm hoping we can actually evolve to that stage. And I think this is where large academic centers that have their own health plans really can make a change by experimenting. And with experimental models, actually show savings and then institute changes in care, which benefit themselves by their health plans, but also then become a template for the rest of the country. And I think some of that work is already happening.
Yeah, and I love the way you said experimentation. Policy, we don't do enough of experimenting with new policies. We tend to assume it's going to work, or we have some empirical evidence that it might work, and we push it out for implementation. And experimenting with some of these novel methods is exactly where we might want to go. I'm going to end my last question with you. You have a foreword by Sid Mukherjee and a blurb by Abraham Verghese. Wow. How does that feel to be amongst those two great physician authors?
Oh my gosh. No, I am incredibly thrilled and honored, and in a burst of other additional emotions that may not be adequately emoted in words. no, to have them endorse the writings and the book is just phenomenal. And I'm very, very grateful for both of them taking the time to write towards this book. If I may add out there, Bob, I'm very grateful for you for writing a blurb for this book. I deeply appreciate that, and it means a lot.
Well, thank you. I had a lot of fun reading the book and writing a few thoughts about it. And thank you for being on our podcast here. So thank you, the listener. This has been a fabulous conversation with my friend and colleague, Jag Singh, a cardiologist at Massachusetts General Hospital, a professor of medicine at Harvard Medical School. He is the author of a new book, Future Care. Take a read. It's fantastic. It really does try to get at this issue of the new technologies, how we use it, and how maybe we can disrupt healthcare with this. So thanks for joining us here, Jag, on theheart.org and Medscape Cardiology.
Thanks so much, Bob, for having me.